Good afternoon. I'm Edmund Bonikowski, the Medical Director and Founder of NRC Medical Experts, neurorehabilitation chambers for providing expert witness reports in cases of serious neurological injury. And we thought that the concept of cannabis related to medical legal practice would be an interesting topic for the assembled company. And nobody better to present that than my co-founder one time and now international medical expert in cannabis, Professor Mike Barnes, who has been, I think it's fair to say, single-handedly at the helm of making medicinal cannabis available in this country. And I think one has to take one's hat off to Mike's endeavour over the last 5 to 7 years in this field. He's begun to get some he's begun to get recognition for this, which I'm very pleased to see. So without more ado, Mike, over to you. Thank you very much.
Thank you, Ed, and thank you to Kate for sorting things behind the scenes. Hi, as Ed's kindly said, I'm Mike Barnes. I'm a neurologist, or was a neurologist, and a neurorehabilitation person. I did a lot of medical legal work, possibly with some of you on this webinar, mainly in the field of brain injury, a little bit in spinal injury, and children with cerebral palsy and life expectancy. And I was interested in cannabis for about, from a medical point of view, for about 20 years, when I initially did some work with a company called GW Pharma when they were developing what turned out to be the first cannabis medicine called Sativex, which was licensed for drug-resistant spasticity and multiple sclerosis. There's then a gap of at least a decade because nothing much was happening in the cannabis space. And then I was asked to do a report for a parliamentary group called the APPG on drug policy about the efficacy and safety of cannabis, which I did with my daughter in 2016. And then I was asked to get involved with what turned out to be the first prescription for cannabis medicine in this country with a little boy called Alfie Dingley, who had multiple seizures, rare genetic epilepsy syndrome. And to the campaigning efforts of his mother, really it was, I would give Hannah great credit for a persistent and very successful media campaign, as a result of which the law was changed in November 2018 to allow doctors on the specialist register to prescribe cannabis, and that's where we are. And I'll tell you, during this talk, I'll tell you where we're up to date, where we've got to in what is now pushing 5 years. Which isn't as far as I'd like by any stretch of the imagination. But what I'm doing now for probably about 45 minutes is just to go through a little bit of the history of cannabis, a little bit about how it works through the endocannabinoid system, a little bit about the plant and the cannabinoids in the plant, then what we use it for, mainly today, particularly relevance to neurological and pain indications, which is what it's mainly used for. And a little bit then we've got some questions at the end that Kate and others have put together about questions that might be particularly relevant for medical legal practice and legal teams, and as well as case managers and clinicians. But plenty of time, hopefully, for some questions that will be chaired by Ed at the end to finish at 5. So I better stop talking, otherwise I won't finish at 5. So let's have a quick look at cannabis. That's that's me and that's Ed, so that's nice. And if you have just a quick point about, if you want to write a question, do put that on the Zoom chat, and Kate will assemble those questions to pass on to us at the end. So let's have a look at a little bit of the history. And I just thought it's worthwhile not spending too much on the history, just 2 or 3 minutes, to say that from a medical point of view, well, start at the beginning. Cannabis has been on this planet for over 1 million years. There's been fossilized seeds discovered way back. But its documented written use of cannabis was first medical, not recreational or social. First medical use was described, actually the first medicine written down and described by man, and that was about 2,700 years BC. And it was a guy called Emperor Shen Nung in southern part of China in the Himalayan foothills, where he wrote and described what turned out to be really the first pharmacopoeia, which included cannabis use for, particularly for pain and probably for epilepsy. The description is a bit lost in the mists of time, but probably for epilepsy. And that was its first described medical use, so a long time, 5,000 years ago. So those who say it's a brand new medicine and we've got to be careful about it are just wrong, because it's the first medicine ever. Its medical use then seems to have spread from China into the rest of Southeast Asia, still well BCE, along the Silk Road into ancient India, along the Silk Road to the Central Asia, into then ancient Egypt, and in ancient Greece and Rome, and spread throughout the Middle Ages as a medical use. This is throughout Europe, and relatively recently across the Atlantic, 1600s into North and South America. Because it was there as a plant across the world, in all continents except Antarctica, all that time, but it was documented use of medicine. That's the path it followed. And this slide, I'm not going to go through all these 38 points here, but you can see it is a historical documentation of the use of cannabis, both as a medicine and as a spiritual aid and a recreational aid, and for hemp for the fiber and for clothing, etc., is well documented for a long time, for many millennia, right across, particularly this part of the world shown in this slide. I won't go through all those individual bullet points at the moment. I thought it might be just interesting just to look at the UK cannabis history, and we know that cannabis was farmed in the UK in the Bronze Age. That's about 850 or so BCE. We know it was grown in Roman Britain, particularly hemp. Hemp is cannabis. Those who don't know, hemp is Cannabis sativa. It was grown particularly for its strong fibre, as I said, for rope, for cloths and such like. The Anglo-Saxons farmed hemp. In the early Middle Ages, hemp was widespread. It centred on Hampshire. I didn't realise that Hampshire was originally called Hempshire because it was the centre of the hemp industry. And over that period of time, in the very early Middle Ages, it was widely used as a medicine, as an anaesthetic, treatment of gout. We might use that today for pain, weight loss, infections. It's known to have antibiotic qualities, for example. Then in the mid-16th century, Henry VIII actually made it compulsory for farmers with more than 60 acres of land to farm at least a quarter of acre for hemp, which of course he wanted for rope and sailcloth for the ships, particularly. In the mid-17th century, cannabis was included in the London College of Physicians pharmacopoeia, so they were more advanced in the 17th century than they are in the 21st century. And the point of that slide really is just to illustrate, there's many other slides I could illustrate, that shows that cannabis was simply a part of medicine, an integral part of medicine, not in any way stigmatized, up to about the 1930s, when it became, well, it was beginning to be outshone by the emergent pharmaceutical industry, and then various international laws came into effect that began to stigmatize it really and preclude its prescription. I think the next slide just summarizes very briefly that history. So 1925-ish, mid-20s, there was an opium convention actually in Geneva that added cannabis to narcotic drugs they were trying to control internationally. That was its first sort of, first nail in its coffin, I suppose you could say. In 1928, the UK first prohibited cannabis as a drug, but the doctors could still prescribe it, and he did so until the 70s. 1937, the United States passed the Marijuana Tax Act, which prohibited most use of cannabis on a federal level. And it's still federally legal in the States, even though it's now legal medically and increasingly recreationally in about 35 states in the States at the moment. All that internationally culminated in the United Nations Single Convention on Narcotic Drugs 1961, which stuck cannabis in Schedule 1, Schedule 4, which made it, by definition, it had no therapeutic value and significant side effects, which of course is totally untrue and contrary to 5,000 years of history. The signatories to that convention that had to produce their own national regulations. Misuse of Drugs Act was the UK in 1971, as many of you on this call will know. And since then, it's been listed as a Class B drug, except for a brief period. I think it was Tony Blair, where it was a Class C drug from 2004-2009, and George Brown moved it back to B, which is more restrictive, of course. And it was only, as I said, till the early 1970s when it was not available for prescription. But then following Hannah's successful campaign, the Misuse of Drugs amendment was amended to include the ability for doctors on the specialist register to prescribe cannabis. and any other doctor to do follow-up prescriptions, but a doctor on the specialist register, that's a hospital consultant effectively, has to initiate that prescription. And so from 1971 to 2018, it was very much restricted, and it's still fairly restricted, I have to say today. It's still for non-prescribed cannabis. It's still a Schedule 1 drug, which means by definition has no therapeutic value, but magically the same drug changes into something with some therapeutic value, a Schedule 2, once a doctor signed a prescription for it, the magic of the doctor's pen. There's lots of ridiculous anomalies in the UK law. So that very brief, I'm sorry it's so brief, but we're not here to talk about the cannabis history, but it is interesting, and I hope that's of some interest to you. So where are we today? Well, as I said, in the UK, it's not the Channel Islands or the Isle of Man where GPs can prescribe, but in the UK, mainland UK, a doctor on the GMC specialist register can initiate the prescription. The CBMP, they call it, is a cannabis-based medicinal product. And any other doctor, or indeed others such as a pharmacist or nurse who's gone through the prescribing courses, can continue that prescription thereafter. I'll go through some of the facts and figures towards the end of this talk on where we are in terms of numbers today. In the UK, I think to applaud the people who changed the law, the Home Secretary then was Sajid Javid, and the Health Secretary was Matt Hancock. They changed the law, and there are no restrictions on what it could be prescribed for, which was actually quite good. It's mainly prescribed, I'll show you in another slide, for pain and anxiety and such like, but there are actually no restrictions. As long as the doctor feels it's in the best interest of the patient to prescribe, it can be prescribed as a Schedule 2 controlled drug. And that's where we are today. And that's where we are, the trend across the rest of the world. So let's put this thing in here because it's now legal or decriminalized. It's various shades of green, as it were, for medical use in over 70 countries worldwide, including some surprising places like Thailand, where up to fairly recently it was heavily punished, its use or its possession, and other places, a big chunk of South America, increasing numbers in Africa. Australia is a big producer and user, etc. And of course, Canada, where it's legal recreationally as well as medically, and most of the states. So, and predominantly around the world, it's GP prescribing. So a little bit of an anomaly in terms of insisting it's via consultants in the first place. So let's just briefly, and it will be brief, have a look at how it works, or how it mainly works. It mainly works with what's called the endocannabinoid system. I'm not going to launch into a complicated description of this system, but let's have a brief go at it. The endocannabinoid system is the most widespread neurotransmitter system in the body of all vertebrates, not just man. It's a complex cell signaling system, as it says there. Really what it does, it acts as a sort of homeostatic mechanism, a balancing mechanism, a negative feedback loop to the other neurotransmitters. It switches things off. And I'll show you the next slide, which will probably put some of you off, but I will do my best to go through it. Some of you will know this, some won't. There's billions of nerves in the body, therefore, and they join with each other, but where they join, they don't actually physically touch. There's a gap in between those nerves called the synaptic cleft. When a signal comes down one nerve, on this slide, it's the top nerve called the presynaptic nerve. It doesn't physically touch the next nerve down the chain, which is called the postsynaptic nerve. How that electrical signal is transmitted is by a release of a little packet of chemicals called neurotransmitters. I'm sure all of you will have heard of some of these neurotransmitters. There's about 100 of them. This slide shows glutamate and GABA, but others will be familiar, like dopamine, opioids, serotonin, adrenaline, noradrenaline, etc. And that packet of chemicals is released in response to the electrical signal. It crosses that synaptic cleft, links with the nerve on the other side, which initiates an inrush of calcium, which initiates the signal to go down the next nerve to its end point. Now, if you think about it, that signal will need switching off. Otherwise, it will carry on forever. It switches off by natural degradation of the neurotransmitter, of course, but it's also switched off by the endocannabinoid system. And I'll explain these complicated-looking arrows. When that signal is detected, an endocannabinoid, as they're called, in this slide it's illustrated as anandamide, is formed on demand. It's not sitting there, it's formed on demand. When anandamide is formed, it gets released from the postsynaptic nerve and goes backwards across the synaptic cleft in the other direction, links with the receptors on the other side, called cannabinoid receptors, CB1 and CB2 mainly on this slide. And that linkage of the anandamide, the endocannabinoid with the cannabinoid receptor switches off the transmission. I won't go into how it does. As soon as anandamide's done its job, it gets broken down and waits for the lexicon to come along. It's as simple as that. And I hope that's not too simplistic, but that's roughly what it does. It's a negative feedback loop, if you like. It switches things off. It restores things to its natural resting state. But what does that mean in practical terms? Let's look at, I'm not going to go through all of these in detail, but let's see what the endocannabinoid system actually does. Remember, this is nothing to do with the plant now. It's just our own inbuilt natural endocannabinoid system. Well, as I've said already, it's a homeostatic mechanism. It's a balancing mechanism. It balances things that are slightly abnormal. So pain, for example, is abnormal. It will calm that down. It regulates, for example, anxiety behavior. Has a role in extinction of memory, old memories. You can see a role in PTSD, for example. It increases appetite, which of course a low appetite is abnormal. These are things that you want to be restored to its normal resting state. So it increases appetite. Inflammation is abnormal. It has an anti-inflammatory role. It's analgesic role. It regulates temperature. It promotes sleep. It reduces overactivity of the muscles, so-called spasticity. It has a role in formation of new nerves and a role in the adjustment of existing nerves, called neuroplasticity. It has a function of, for example, reducing tone in the bladder. It reduces function in the gastrointestinal tract. It's anti-inflammatory, so it has a role in things like inflammatory bowel disease, Crohn's disease, ulcerative colitis. There's a role in other things like implantation of the embryo. Has a clear role as an anti-proliferative cell response, in other words, an anti-cancer role, a natural anti-cancer role, and a critical role in learning and memory. So that's a huge range of things. Because it works on every neurotransmitter system, you can see why it has a role in virtually every bodily function that's controlled by a nerve. So it is the most important neurotransmitter system in the body. Oddly, it's only been known about, indeed, about 30 years, but it's still not really taught in medical schools. It's really very much unknown amongst most medics and other allied professions. And it's through the endocannabinoid system that the plant cannabis works, because those cannabinoids in the plant, the so-called phytocannabinoids, interact with this endocannabinoid system and modulate it, add to it, supplement it, etc. And that's very crudely and not quite accurately how the phytocannabinoids work. I say not quite accurately because the cannabinoids in the plant can also interact with other neurotransmitter systems other than this one, but that's pretty well how it works. So let's have a look at those cannabinoids in the plant. We'll all have heard of THC. That's the one that gets you high. But actually, the plant has got a bit of a bad rap, as it were, because there's about 147 cannabinoids in the plant, of which THC is just one. And only legally speaking, 12 of those are controlled cannabinoids, which are meant to those get you high. In fact, probably 4 or 5 or 6 of those that the law has determined are controlled cannabinoids probably don't get you high, in fact. But let's assume that they're right for the moment. There are 4 clear cannabinoids that do get you high. Delta-9 THC is the main one, which is very high in street cannabis, because that's what it's there for, to get you high. There's another one called Delta-8, THC light, a breakdown product of THC called cannabinol, and another one called THCV. But there are others as well, which I won't go into. But they're the you could call them psychoactives, not quite the right word, because anything that acts on the brain is psychoactive, and CBD, which I'll come to in a moment, is psychoactive, but it doesn't get you high. So a better term is not gets you high. Intoxicating is not quite right either, but let's call it the high-inducing cannabinoids. And let's just look at one of them, THC. What does THC do? All by itself, not with anything else in the plant? It's a really useful medicine. It's analgesic, very strongly analgesic. It protects the brain. It's antioxidant, therefore has a role in some neurodegenerative diseases like Huntington's chorea, multiple sclerosis even. It relaxes muscles. It's anti-sickness, and it's very strongly anti-inflammatory, twice as powerful as steroids and 20 times as powerful as aspirin, for example. So you can see those, look at those lists of things that THC does. You can see THC is a very good medicine. It's limited as a medicine because it gets you high. So what we do medically is combine it with some of those cannabinoids that don't get you high, particularly CBD. You put CBD with THC, it doesn't get you high. It counteracts the high. So a sensible prescribed medicine, cannabinoid medicine, will not get you high. If you get high from it, it's pretty well a failure of prescription, a failure of the doctor to do the right job. So let's have a look at some of those other non-psychoactive phytocannabinoids, those that do not get you high. And the one we've all heard of, because it's all over Boots and Holland and Barrett, and is cannabidiol, CBD. But there are 135 others. I've put just a few there, random names, CBC, CBG, some of you may have heard of, probably not most of them. But let's have a look at what CBD does, in isolation, all by itself, not with the rest of the plant. It's neuroprotective. It's very strongly anti-anxiety. It's strongly anticonvulsant, and it's CBD that little children with epilepsy mainly take. It's anti-sickness, and of course, we've said already, it's not intoxicating. So again, CBD by itself has very useful properties. It also is mildly pain-killing. It promotes sleep, wellness issues. We read over the counter. It helps aches and pains of everyday life, like after a gym session, helps you sleep. As I say, it reduces the stresses of everyday life. But it's a very useful medicine, medical medicine, not just a wellness medicine, particularly for its anti-anxiety and its anticonvulsant properties. But there are others. I'm not going to go for too long in all this, but they're not that simple, as you might imagine. The plant is not just CBD and THC. It's all about lots of other cannabinoids. And I won't go into this in too much, so do not panic. But the mother cannabinoid, the one that's first formed in the plant, is called CBG, cannabigerol. You might have seen it over the counter. It's a legal over-the-counter product. That breaks down as the plant matures into THC, we've talked about, CBD, we've talked about, and another one called CBC. The A is for acid. In the plant, they're formed as acid precursors, which don't get you high. So you can mash up a flower of a cannabis plant, make it into a smoothie if you're so inclined, and you won't get high from it, because you need to get rid of that acid component, which you do mainly by heating, such as smoking, or in the form of forming oil. The industrial process will heat it and get rid of the acid. But the point of all that is just look at just two of them. Just look at CBG and CBC. And these also have medical properties. They're really interesting. Anti-cancer, CBG, anti-inflammatory, reduces bladder tone, reduces pressure in the eye. It's antibacterial. It stimulates appetite. And that's just CBG, and that's a legal product, and you can buy it over the counter. Let's quickly also look at CBC, another one in that chain I showed you. It's also anti-inflammatory. It's very good for inflammatory skin conditions like acne and psoriasis. It's shown to have antidepressant properties in man, and it has anti-cancer properties. I'm not sitting here incidentally saying that cannabis is wonderful for cancer, because that's way off in the future. It may be for some cancers over time, but I'll show you what it's really useful for in a little bit of time. So there's a lot of those, and all those cannabinoids studied, which is, we know quite a bit about two, a little bit more about another half a dozen, 8, 10, and precious little about another 130 or so. But all those studied do seem to have very interesting and potentially helpful medical properties. And the whole plant put together, the full spectrum products, they all seem to work in synergy, and they're better than the isolates. You can isolate CBD, you can isolate THC, which have medical properties, as I've shown you, but the whole plant together is better than those individual components. That's a so-called entourage effect, which is scientifically now, without any doubt, the case. So when we prescribe cannabis medicine, we're prescribing a full spectrum product. Not quite finished, because I think when you walk down the street and smell cannabis, you're smelling the thing called terpenes. They're volatile chemicals. There's about 100 of them in cannabis, and I'm not going to go through them, but some of them are there. They're also in all plants that have a smell. So myrcene smells of herbs, for example, hops, for example. Linalool is in lavender smell. Limonene is citrus fruits. Pinene is pine, not surprisingly. And beta-transcaryophyllene smells of cloves. So those together give cannabis its distinctive smell in various shades, because over 2,000 different varieties of cannabis. And they also have medical properties. So you put all those 137 cannabinoids, 100 terpenes and other things that give plant their color, called flavonoids, another 100 of those. Put all that together, the cannabis plant is a very complicated mix of very interesting medical properties. So let's have a look at how the cannabis plant can help various neurological conditions. Well, first, let's have a look at what it's actually prescribed for at the moment. This is from a study by Drug Science. Professor David Nutt has a charity called Drug Science, doing a project called T21. It now has nearly 4,000 patients on it to have been prescribed cannabis. I won't go through the results of those studies, but suffice it to say that there's now a dozen papers come out which show very convincingly that cannabis has a very positive effect on pain, on anxiety, on sleep, and on quality of life. But there's not time for that today. Let's look at the what do you call the thing, pie chart. And this is what it's used for. There's now about 31,000 patients prescribed cannabis in this country, and just over half are using it for pain, chronic pain. It's a very, very good chronic painkiller. Another high proportion, 41% or so, are using it for psychiatric conditions. That's mainly anxiety and related conditions like PTSD or fibromyalgia that has both pain and anxiety elements. It's not a disease curer, it's a symptom helper. And it helps anxiety symptoms, it helps sleep symptoms, it helps pain symptoms particularly. And then there's a small amount, about 10% or so, of neurological conditions like multiple sclerosis, where it helps the muscle spasm as well as pain or anxiety. Gastrointestinal conditions I mentioned earlier, like Crohn's disease. It's about 10% are neurological indications, but mainly it's pain and secondary anxiety. As I said, most evidence is for pain, anxiety, spasticity, sleep, and of course epilepsy. We shouldn't get small numbers, because those children are tiny in the scheme of things, but they're really important because come back to my Alfie's example, he was having about 400 seizures a month in intensive care every week in the year before his cannabis, 48 times in a year, and he's now coming up to his 4th anniversary with no seizures at all. And all that's changed is he's been introduced to cannabis. So for some children, the effect is not just excellent, it's remarkable. And that's improved his quality of life and, of course, his family's quality of life immensely. So it's verging on the miraculous for epilepsy sometimes. But there's good evidence base. So those who say there's not a good evidence base don't know the evidence. There's a lot of real-world studies, because it's time not to explore it really, but cannabis doesn't really lend itself to double-blind, placebo-controlled classic pharmaceutical medicine because it's not a single compound. It's difficult to get a placebo. The people who use it have multiple conditions and such like, which I can explore with you if you like. But treating it as a pharmaceutical and treating it and accepting evidence as it's a pharmaceutical will never work, because cannabis doesn't lend itself. It's not a pharmaceutical, it's a botanical. And there's overwhelming real-world evidence studies, something like 50,000 studies now, increasing monthly. Now it's legal around the world. Lots and lots of people are doing further studies. Well, that's the main evidence base. Let's explore that a little bit further for what your clientele may be interested in, which is, I know, mainly neurological, mainly brain injury or spinal injury. Let's start with a couple of other things that you may or may not come across particularly, but it's shown now efficacy in Parkinson's disease, the motor symptoms of Parkinson's. Remember, it doesn't cure Parkinson's, doesn't slow it down. It just helps the symptoms of Parkinson's, like the motor symptoms, the bradykinesia, the tremor, and the rigidity particularly. In Alzheimer's, again, to state the obvious, it doesn't slow down Alzheimer's disease, but it improves some of the really disabling quality of life issues in Alzheimer's, such as agitation, anxiety, sleep problems, appetite problems, depression, and such like. So it's finding an increasing place in the symptom control of Parkinson's and Alzheimer's, to start with. Oh, we got the time, right? Brain tumors. Again, some tumors generally seem to be very sensitive to cannabis, particularly one called the glioblastoma. It's shown as better survival, and a combination of cannabis with, I can't ever pronounce it, temozolomide, which is a anti-brain tumor chemotherapeutic agent. I think over fullness of time, we'll find out some particular cancers are particularly sensitive to cannabis, probably some types of breast cancer, some types of pancreatic cancer. But again, I'm not promoting it as anti-cancer, though there's plenty of that promotion on the web. But I am saying that I think it could find a very interesting place in the management of cancer. But don't forget it, whatever cancer you've got, it will help symptom control in cancer. So I had terminal cancer. I would use it because I hopefully will help my anxiety, reduce seizures if I got seizures, It will improve appetite and sleep. It will improve pain if I have pain associated with the cancer. So as a symptom controller, quality of life improver is very helpful for any type of cancer. Look at traumatic brain injury. Again, come back to the same point, symptom control for anorexia, anxiety, seizures, pain, appetite, psychotic symptoms, remember, behavioral problems, CBD, not THC, but CBD can help those improve sleep. And those things there, as many of you on this call will know, are really many of the significant issues associated with the long-term problems of traumatic brain injury. And it has a neuroprotective role as well. So it's useful as a symptomatic treatment for brain injury. What else? Increasing evidence is useful in dystonia and Tourette's, Huntington's. We've mentioned sleep disorders, of course, and overactive bladder is helpful as well. Just as almost not really an aside, but it's increasing use for autism spectrum disorders and ADHD, reducing the behavioral problems of those conditions. A nice study showed that. Not wonderful, but it is really helpful, showed behavior improvement in about 60% of the children who had taken it with really little side effects. And as to that point, I haven't got a slide on it because it's not time, but the side effects of cannabis are very mild. CBD, can't say it, nothing has no side effects. CBD has very mild side effects, mainly shared with THC's drowsiness, dry mouth, and dizziness. CBD also has stomach cramps and diarrhea, and THC, of course, can get you high if you're not careful about the prescription. But generally, that T21 study I mentioned earlier showed an extraordinary statistic of 97% of those 3 months after initiating the treatment had no side effects. And that was a random selection of any type of cannabis, any type of disease problem. So, side effects are there, but they really are very mild and very well tolerated. I'll come to contraindications in a moment. Psychiatric conditions with good evidence base for anxiety, as I've said, and PTSD. A little bit of emerging evidence of obsessive compulsive disorder. Remember, CBD is antipsychotic, whereas THC can cause psychosis in certain circumstances, which we'll talk about in a minute. But CBD is antipsychotic. Not that much evidence for antidepressant properties. Mainly, it helps depression in the sense of better sleep and less anxiety. Of course, and there's good evidence of promoting sleep, which is a big complication in many psychiatric conditions. So they're the main things it's used for that builds on that pie chart I showed you earlier. Let's just, before we go on to a couple of other things, let's put on the side of how we're doing for time. We're fine. Dave, this is a real case study, happens to be from Canada. Doesn't really matter. This was a guy who had a 55-year-old brain injury, metal scaffolding fell on his head. He has resulting seizures and traumatic headaches, usual issues like memory problems and fatigue, and he hasn't used cannabis before. He's on a lot of medication, which we won't bother about, except clobazam is something you've got to watch a little bit with cannabis because the level of clobazam can go up in the blood, but that's getting a bit too technical. And what the doctor who prescribed for him, just as an example, really, I'm not going to go into how you prescribe cannabis today, but she started him, as we should do, on a low CBD. The same stuff you can buy over the counter, except it's full spectrum, which means it has a little bit of all those other ingredients in, including a little bit of THC, which will probably be enough to make it illegal as an over-the-counter product, but still a tiny amount of THC. When it says 1 to 20, that means 1 part THC to 20 parts CBD. So it's very high in CBD and very low in THC. She started a low dose. It doesn't really matter for this talk what it is. It happens to be around 7.5 milligrams a day. Build it up slowly to about 100 milligrams a day. That's the sort of average dose of CBD. So if you buy it over the counter, you need about 100 milligrams to have a medical effect. The Food Standard Agency, in its wisdom, said don't take more than 70 milligrams a day based on no evidence whatsoever, which of course excludes its medical effect from most people, which is sort of slightly bizarre. But I don't know why they said that, but who knows. She then added in, what you tend to do is start off with CBD, you then add in a little bit of THC if you need it, and you often need a little bit of THC for anxiety, for example. Certainly for pain. Pain is the thing that you need probably more THC than most. A little bit of THC for epilepsy. So often it's the combination that's important, not just CBD, not just THC, but the whole plant, as I've said now. So she then added a little bit of THC oil, just a tiny bit, just 2.5 milligrams at night, ended up at just 5 milligrams a day. That's a tiny dose compared to the CBD, which was 100. She added a little bit of flower for vaping, because you can vape legally, which is good for getting people off to sleep. It's good for very good for sudden pain, like breakthrough pain, or things like trigeminal neuralgia or cluster headache, or an aura of migraine, for example, or panic attack. So when you want an immediate effect, vaping is very useful. So with that combination of CBD, THC, and a little bit of a vape, he was off half of his morphine, increased energy, better pain control, and much improved quality of life. And it is a generally typical story. I just wanted to put one up. There's many other case histories I could have showed you, but I just wanted one up that's relevant to brain injury. So what's next? So this is where we are in the UK now. Just so you know, there's 31 online clinics, all private, with 12 pharmacies. There's now about 120 doctors prescribe in the UK, which you think about it is tiny, well over 100,000 doctors in this country. 120 just have got the, I really said balls to prescribe, but I've said it anyway now. There's all imported at the moment. There's a lot of product in the country. We have no shortage of product. Almost have too much, 194 different cannabis products in the country at this moment. But what doctors will tend to prescribe from all that range is 60% is for flower, for that acute pain, and we often find that legacy users, previous illegal users, do prefer regular vaping to a background oil. For pharmacological, I can't quite understand that, but nevertheless, that's a statement of fact. And 40% or so are oil, and we haven't got much else in this country. So you either get a flower for vaping, or you get an oil to put on, hopefully to put under the tongue, or swallow if you have to. Put it under the tongue gives you a good, reliable, consistent effect. We will soon have a UK industry. There's 12 growers now in the UK with licenses who will produce back end of this year, early next year, in different parts of the country. And overall, we now have 31,000 or so UK and Channel Island patients. And we have 5 in the National Health Service, which is a bit sad, because when the government voted to change the law, I think they were voting to change it for everybody, not just for those who could afford a private prescription. And that's a big issue. I'm happy to explore the politics behind that issue if you like to, but I'll keep off it just for the moment. That's the statement of fact. At the moment, there's 3 of those are children and 2 of those are adults. 5 on the NHS. And 31,000 privately. That's where we are. So it's quite a big market. If you ask people in the street, around 2/3 don't know that it's legal to prescribe, interestingly. Astonishes me, because I've spent 5 or 6 years working in nothing but cannabis, but it's astonishing that there's meant to be about 1.8 million people in this country who use cannabis daily for medical conditions. That's not the recreational market, which is about 3 million, 1.8 million for medical use only. Okay, there's an overlap, but mainly for medical use. So we've barely scratched the surface, 31,000 compared to 1.8 million, let alone those who aren't using it at the moment, but would benefit, but don't know how to get it, or don't want to criminalize themselves. So the total market is probably, if you extrapolate from Guernsey, about 4% of the population in Guernsey, where it's been legal for a couple of years now, are now on medical cannabis. 4%. That's about the figure internationally, 3 to 4%. So 3 to 4% of this country is, I can't work out what 3 or 4% of 66 million is, but it's 2 to 3 million people should benefit from cannabis. In fact, we've got 31,000, means we've barely started. So let's have a look at just a few questions. I'll go through these in 5 minutes or so, and then we'll stop for some questions that might be online. So let's have a look. These aren't in any particular order. The validity of medication. If you've got a cannabis prescription, if you've got carrying cannabis with you, what you should do is keep it in the container and keep the prescription with you. There's many cases that come to my attention, and I'm sure yours, as from the legal point of view, is that the police illegally, I think that's the right word, seize legal cannabis because they say, no, it's not legal, mate, you're pulling the one over our eyes. And it is sadly the case that many of the police forces in this country do not yet know that it's legal. I think is a very sad reflection. So if you've got a cannabis prescription and it's legitimate and it's been provided by a proper medical practitioner, use it by all means, but keep the prescription with you and in its original container. I'm not going to go through the recommended dosage. As I said already, the recommended dosage is up for adults about roughly 100 milligrams of CBD, sometimes more. There's no absolute limit. The children, incidentally, use much higher than that, about 10 milligrams per kilogram, which means they're on 400 or 500 milligrams of CBD for their epilepsy. You need much more. There are no restrictions on the method of administration except for smoking. Smoking remains illegal in this country. So if you have the flower, it has to be vaped. You cannot smoke it. But any other method of administration, such as edibles or oils or patches or suppositories, are legal. Trouble is, there's virtually none available legally, and it's mainly down to flour for vaping and oils for administering under the tongue or perhaps from swallowing. Of course, the patient should be provided with adequate guidelines on how and when to consume it, because it's usually not a straightforward. It's not a matter of take one of these 3 times a day and come back and see me in 2 months. It does take a quite a thought through process of slow increments. Start low and go slow is the usual recommendation. In build it up slowly, so people need that writing down for them to gently build up over 2 or 3 months to a good dose. So they should have been provided with those guidelines and should have them handy. Does cannabis impair you in terms of your cognitive or motor skills? Well, street cannabis can do, clearly, but we're not talking about street cannabis. We're talking about medical cannabis, and medical cannabis should not cause impairment. Okay, for those with severe pain who might need a high THC dose, they should still be counteracted by the CBD. It's just possible there's a bit of breakthrough highness, if that's the right word, for those with very severe pain. Therefore, it can impair you for a short period of time, perhaps an hour or 2 hours after taking it. That's unusual, but it can occur. But generally speaking, cannabis does not impair, medical cannabis does not impair your cognitive intellectual functioning, because the doses are lower than street cannabis and the constituent products are different from street cannabis. Are there contraindications to using it in the first place? Yes, it's not suitable like any medicine. It's not suitable for everybody. I wouldn't prescribe it to those with any active psychosis or recent history of psychosis, recent history of heart attack or stroke for about 3 months, because it can affect blood pressure and heart pumping, if you like. Excuse me. So it shouldn't be prescribed for everybody. Probably you exclude about 5% or just less of those who want it are not suitable to have it. So it's suitable for most people. And of course, they should be advised about potential side effects, which I've mentioned about dizziness, drowsiness, dry mouth, in relation to operating machinery or driving. If you are dizzy or drowsy, of course, don't drive. You shouldn't drive if you're impaired or operate machinery. So warning people about the side effects is clearly very important. I've sort of covered that already. History of substance abuse or dependence or psychosis or mania, would you think carefully? And it's not an absolute contraindication. If you had a history of psychosis as a teenager, and you come back in your 40s or 50s with back pain, I wouldn't hesitate to prescribe. I'd start with a CBD, which doesn't get you, doesn't have a risk of psychosis, and build it up very slowly and cautiously. So there's not much as an absolute contraindication. Liability incidents, were there any accidents, injuries, or incidents that occurred while the patient was under the influence of prescribed cannabis? That's very unusual. Again, I say that again, it's medical, not street. And of course, there can be, if you're high with street cannabis, of course, you can have potential problems, but not really to any significant degree with medical prescription. Do you require any accommodation at work or at school? Not really. I mean, what you really need to do is just be open with the employers or educators and tell them I'm on a legal cannabis prescription. Otherwise, they won't believe you. All you really need to do for those who need to take it and vape it, particularly, is provide an area to do so, like a smoking area outside, for example. There's no absolute accommodation you need except for that. Obviously, people wouldn't particularly want you to vape in the office, like you wouldn't want to smoke in the office these days. So that's pretty obvious. But there's no other particular accommodations. We hear of lots of cases, not in the proportion, but lots of cases where the employer has said, no, you can't smoke cannabis, take it off these premises. And a body called the Cannabis Industry Council, CIC, have now produced a very useful guide for employers, which pass through some lawyers to hopefully we get the law right about what employers can and can't do in terms of restricting access to a legal medicine for those who need it. And that basically they can't restrict that access. Are there legal restrictions about transportation, storage, consumption? No, there's none. There are no legal restrictions about how you can carry it around. You can smoke it where you like. Obviously, the exception to that is please don't. There are some people who are so sort of pushy for prescription of cannabis that they go into a local pub and smoke it and say, I've got a legal prescription, you can't stop me smoking, which isn't really helpful. Let's be sensible about it. And if you do have to vape cannabis, then go outside and do it. So there's no legal restriction except on private premises. But lawyers I'm talking to here can tell me probably the legal owner of the premises can restrict what they want to happen on their premises. So I'm straying outside my area. But otherwise, there are no legal restrictions about transporting or storing or consuming the legal product. Prescription is valid for a month. Obviously, you can use if you get a prescription and you're not using it all because you don't need to vape every day, you can use it for longer than a month, but the prescription lasts a month. And you should have a scheduled review and follow up with the medical practitioner who started it to evaluate effectiveness and side effects, particularly for the first couple of months till you've got a sensible, stable dose. And finally, the driving regulations, before I shut up. I'm sure many of you will know there is a legal limit for THC, it's 2 micrograms per litre. You will be over that limit if you're on a regular medical prescription that contains THC. Why is that? Because THC is stored in the fat reserves of the body and comes out into the bloodstream slowly but surely. So you will be over that limit, but you won't be high, you won't be impaired, except perhaps for an hour or so after each dose. You shouldn't drive whilst impaired, but you can drive whilst you're over the limit if you have a medical defence. And that medical defence is that you have a legal prescription and you're adhering to what that prescription says. And that medical defence means you shouldn't be taken to court for that reason. I think it's time for questions. I think, Kate, you must advise me now. I think I'm made to stop sharing the screen, don't I?
Yes, please stop sharing the screen. I think Ed's going to come and have a look at the questions.
So if I put Ed back on the screen, I'm happy to answer any questions now. We've got 10 or 12 minutes left. So there we are.
Thank you very much, Mike. I mean, a fantastic run through the history and the applications, indications and so forth for cannabis. And I think, from what Mike said there, we can see why this is such a potentially fruitful source of therapeutics for our patients, particularly with complex neurological disorders. And, just 2 very quick points, Mike. One, I saw a lady in clinic only 3 weeks ago who has MS, and she had an array of the complications and impairments that arise. And she ran me through all the different drugs she was taking and the history of the drugs she'd taken. And one by one, she was ticking them off, saying, and this didn't work, and that didn't work, and that was only marginally useful. And we were working through her situation, and I was beginning to sort of summarize it in my head. And then right at the end, she said, oh, by the way, I do, rather shamefully, she said, have access to street cannabis. I make cookies out of it. And if I take one at night, I sleep brilliantly. I'm not woken up by pain in my hip and my thigh, and my bladder doesn't wake me up. And the thing that I did was I referred her to your type of service, because it seemed to me the most appropriate thing to do. So that was one interesting experience, which I'm going to ask you about again in a moment. And also, I had the privilege of going over to Canada in 2019 to be with Dr. Chris Blue for 4 days, who's a cannabis expert physician over there. And it was fascinating all that time ago to see what full-on cannabis prescribing can achieve in patients with complex problems. And I came back full of hope for the UK cannabis scene. And it's very sad to see that, we have only 5 patients with NHS prescriptions so far. Yes. So those are my reflections on this. Mike, we've got a couple of questions. We'll just go through them quickly. One has just been, I think, answered. Can you prescribe for people who've got a dependence to drugs like cocaine? But I think you've already told us that you can't.
Well, you can. What you can sometimes do with things like cannabis dependency is not obviously prescribe THC, because that's the last thing you want to do. You can wean them off it by substituting the THC for CBD.
So that was a cocaine dependency.
That's cannabis dependency. Cocaine dependency, yes. There are some people who say that you can do a similar thing with those that are dependent on cocaine or heroin by slowly substituting the cannabis for cocaine. It's not my area of expertise, but I know there are some psychiatrists who are now using cannabis as a sort of means of getting off those other drug dependencies.
Yep. Okay. Do you know any client who is going through the medical legal process having been prescribed cannabis? Do you?
Yes, there are some. Yes, we
Okay.
haven't kept a sort of database of it, but yes, it's not uncommon now for to be used in mainly traumatic brain injury, spinal injury, as we've said. They're the people who tend to go through a medical legal process. And yes, a proportion of those, I couldn't give you a percentage, I just don't know, will be on cannabis, legally prescribed.
Interesting. My reflection on that particular question is that I haven't come across anybody who is being prescribed it. And I think that's really just speaks to the general incidence of this kind of prescription. There's a question here, says, are there still the risks associated with vaping, for example, popcorn lung, when vaping with medical cannabis? I've never heard of popcorn lung. Have you?
I presume, no, quickly, I presume they mean some of the issues of the vaping mainly from the States. Is that right there for someone who mentioned the question wants to come across? There is, I think that was due to the excipients used in those vapes in the States. Now, maybe answering a question you didn't ask, but I think that's what you mean by that. And the answer to that is no. Because we don't, mainly when it's vaped in this country, nearly always, you just put the dried flour in the vape machine. It's not mixed with anything else. There's now a few pre-mixed capsules that you can put in a vape machine, and therefore the capsules are mixed with something else. But no, is the quick answer to that.
Okay.
It's a good answer. Considering I don't know what popcorn lung is, but I think that's the correct.
Well, perhaps the questioner would like to just send us the answer what it is. Hang on. Right, hold on.
Yeah.
So I think you've answered this one as well. It says, are there long-term side effects associated with medical cannabis, such as psychosis, which I believe is associated with street cannabis?
Well, just to emphasize, you're quite right. Yes, it's very rare. Even in street cannabis, it's blown out of all proportion by some elements of our press, I have to say. But there's a lovely study by a guy called Hickman who showed that you had to stop 10,000 males and 29,000 females from smoking street cannabis to prevent one episode of psychosis. Yes, it does. And as I said, I wouldn't prescribe someone active psychosis because THC can cause psychosis. But again, we're not talking about street cannabis, we're talking about medical cannabis. Same plant, different product, if you will. So okay. I've never heard of an incident of psychosis from a medical prescription. I'm sure it's happened. I'm sure it will happen, but it's extremely rare.
Thank you. What are the barriers to obtaining an NHS prescription? Is it simply lack of knowledge amongst consultants, lack of availability, etc.? In fact, I was going to come to this question myself.
Yeah, well, now I shall be delighted to get political. Two, you might have to shut me up, Ed. There's two main barriers. Let's do the governmental barrier, first of all. The government changed the law and said, we've done our job, guys, aren't we lovely? It's now down to the doctors. But unfortunately, they laid in the path a lot of obstacles for actually prescribing. Main one is finances. Matt Hancock, bless him, did say, because I was there when he said it, he will make sure that there's not a financial barrier to prescription in the National Health Service. Like many things, that wasn't true. There are a lot of financial barriers to prescribing cannabis on the NHS. Mainly got the trusts. If you work in a trust, they say, well, we're not funded for it. If you work in the GP world, cannabis, now not called clinical missioning groups, but you know what I mean, they say, well, we're not funded for it. So it goes to NHS England, they say, well, we're not funding anyone for that. That should be down to the local hospital. So they go round and round and round in circles. And what we're trying to do, as lobbying through the Industry Council and other bodies, is to get the government to organise this themselves and make sure there's a funding pot for cannabis. That wasn't meant to be a pun, a pot of cannabis funding. That's one thing. A couple of other barriers, like you have to get a multidisciplinary team approval when you prescribe it, which happens to no other medicine as far as I'm aware. So a doctor can't say, I think I'll do this. You've got to go off and get approval for it, which is another barrier. Not allowing GPs to initiate prescription is a problem because a lot of this is GP country, if you like. Sleep problems, appetite problems, anxiety problems, some pain problems is GP territory, but they can't initiate the prescription. They've got to go via a hospital consultant. That's the government. So the other things the government could do to improve things. The other side of that is some of the medical hierarchy bodies, like the Royal College of Physicians, and my favourite example is the British Paediatric Neurology Association, who are implacably against this for reasons one can speculate about, but I don't know why they are so adamantly against it. So much so they write to doctors and say, if you do this, you'll be palming your career. There are many examples of doctors being referred to the General Medical Council because they started prescribing by the BPNA. I find that immoral, and the result of that stance to take children are dying as a result of their attitude, and I'm quite happy to say that publicly, indeed have said it publicly. So there's a lot of these hierarchy bodies that are being deliberately obstructive. I wish I knew why.
There's an interesting little rider to that, and I won't read the whole quote out, but it says one of the attendees was told by a defence union that there should be a pain physician registered under the GMC under pain, and that being a rehab consultant specialist was not sufficient. Interesting rider there.
Yeah, utter rubbish.
Well, absolutely.
We do hear a lot of rubbish talked, I'm afraid.
Finally, a question from me, really, and one that I'm asked in clinic by my NHS patients who can't access it through the NHS. How much is this going to cost me?
Yeah, that's the sad thing about it. There's 31,000 people, many of whom can't really afford it. You've got the consultation costs, which are roughly now not wildly expensive, but something of about £80 on average now. It's come down. That's still a lot of money for some people, of course. But that pales into insignificance when you look at the cost of buying the stuff. The average cost now, which has come down, is about £400 to £500 a month. That ignores the children, which is about £1,500 a month, because they need more for product. So that's what you're looking at, around about £6,000 a year. And of course, these days, the majority of the population can no way afford that. So it's very much the postcode lottery thing, or the private, can you afford it? It's only available to those who can afford it, or those who are prepared to do coffee mornings and mortgage their house. We've heard all these tales. It's very sad, and the government needs to do what it said it would do, which is make it available in NHS. And
no wonder, therefore, that people turn to homegrown street cannabis and so forth for their symptomatic relief.
Well, it's a very interesting statistic, actually, that the average street price of cannabis is £9 a gram at the moment across the country. The average price of medical flower prescribed is now £8 a gram. So it's actually cheaper to get a medical prescription. So it says a lot, but indeed, it should be free. It should be free. That's what the government.
Another final question really says, can you point to any guidance regarding support workers assisting with clients with THC, a spinal injured client who cannot access independently? I'm not quite sure what that question really means.
Well, I suppose if they can't, if there's anyone, obviously with the support going into the Mental Capacity Act, I don't know, there's greater experts than I am on this call. If they feel it's the best interest of their client to have this prescription, yes, you can do it. You don't have to go anywhere. It's all online now, and so getting a prescription online with the support of the carer or the expert required should be fairly straightforward. So it shouldn't be an issue as long as you follow all the relevant mental capacity. Like any other medicine, getting access to cannabis is not different from any other legal medicine. Okay, well, Mike, we're about a minute away from concluding, so I think we'll wrap up there. We've got through most of the questions which came up in the chat. I think I've been around you doing this cannabis thing for several years, and the story continues to get more detailed and more interesting. And I really do congratulate you on those 31,000 patients, which I think would not have had access to cannabis, medical cannabis, without your leadership and intervention. And I hope that some of those 1.8 million that need it, or 2 to 3 million who need it, do eventually get it. And if they do, it will be substantially, I think, as a result of your leadership. So thank you very much for your presentation, and we wish you well with your ongoing work with cannabis. Thanks very much, everybody, for coming. Good evening, everybody. Thank you.